this RN Singh Young Achiever Award session. So, as you all must be aware, what are the rules? So, there will be 5 minutes of presentation regarding yourself and what are your activities, and there is that 1 minute time for discussion. So, we'll start straight away with the first speaker. Pratik Nishant wanted to speak first because he has to go to MC Luka.
Dr. Prasanda's presentation is loaded. Pen hai? Good morning all, esteemed panel, respected ladies and gentlemen. I am Dr. Pratik Nishant. I am a consultant UVI Neuro-Ophthalmology and as well as General Manager Research at Akhand Jyoti Eye Hospital, which is the first center of excellence in Bihar. So I am presenting about this case report which was published in the Canadian Journal of Ophthalmology recently, and it is about adult onset Dandy-Walker syndrome with atypical ocular manifestations. No financial interests. Adult onset Dandy-Walker syndrome is rare and condition usually presents in childhood with hydrocephalus and cerebellar signs. Neuro-ophthalmic findings may be the first feature of the condition, and there are only few reports of the association of Dandy-Walker malformation with cataracts. So a 19-year-old male presented with recent history of having undergone LASIK elsewhere and referred to our tertiary care center for evaluation of bilateral cataracts. And this is the photograph that is taken. The bilateral cataracts are well appreciated. So sutural and blue dot cataracts was seen with an aided visual acuity of 6/7.5, myopic fundi with temporal nasal subtraction crescents and mild temporal pallor in both optic discs, and no peripheral lesions. Axial length of 25.76 millimeter in both eyes. What is very queer about the myopic fundi that we have seen, or the disc that we have seen, that there is very mild temporal pallor which is missed in myopic eyes, but we decided to pursue it further. So automated perimetry was done, and 30/2 showed left-sided homonymous hemianopia with relative sparing of central visual fields, and 10-2 showed relatively spared right macula and left inferotemporal quadrantic macular field defect. On subsequent evaluation, for further questioning, the patient revealed he had occasional difficulty in walking with history of falling down twice in the past 6 months, and suspecting a neurological cause, we did NCCT of the head, which revealed a Dandy-Walker malformation. The NCT scan is showing ventriculomegaly, megacisterna magna, and high attachment of tentorium cerebelli, suggestive of Dandy-Walker malformation. So the patient was referred to the neurosurgeon and followed up 6 monthly, and he had a slight regression of the refractive error. However, visual field defects were non-progressive. The patient underwent uneventful ventriculoperitoneal shunting 2 years later due to worsening gait instability and weakness, and was stable until last follow-up. This is the post-operative scan showing the ventricular drain trip in the anterior body of left lateral ventricle post-operatively with reducing hydrocephalus. So Dandy-Walker malformation is a spectrum of disorders of neural development. It is a classical triad: partial agenesis of the vermis, enlargement of posterior fossa with upward displacement of tentorium, transverse sinus, and torcular, and cystic dilatation of the first ventricle. It is the most common human cerebellar malformation. So agenesis of corpus callosum and non-neural anomalies are also associated, and there is a spectrum of ophthalmic associations of Dandy-Walker malformation that are reviewed in literature. However, there are very few reports with cataracts, and the occurrence of bilateral, sutural, and blue dot cataracts as a presenting manifestation in adulthood is exceedingly rare. In addition, our patient had temporal pallor of both optic discs, which is likely to be missed in high myopic patients. Subsequent perimetry and the findings pointed to a posterior fossa lesion, corroborated by retrospectively acquired history of gait instability, which was then diagnosed as Dandy-Walker malformation. So in conclusion, we encountered a unique case which is rare, and neuro-ophthalmic findings and cataract may be the presenting feature of Dandy-Walker malformation. High index of suspicion and syndropic associations like juvenile cataract, meticulous neuro-ophthalmic workup, and neuroimaging may be necessary. The strengths of this case are the rare presentation, meticulous workup, unique documentation, and the enhancement of the patient's quality of life. The impact of the scientific community is conveyed that this was accepted as a case report in the Canadian Journal of Ophthalmology, and also shared on the LinkedIn page of the Canadian Journal of Ophthalmology as one of their best case reports. these are my references. Thank you. Pardon, sir? 19 years, sir.
19 years.
It was mentioned.
And the grade of the cataract according to logs?
Pardon, sir?
The grading of the cataract according to logs, have you quantified the cataract according to logs, that your classification?
You don't have a particular classification for sutural and blue dot cataracts that was found in the literature. But the bilateral sutural cataracts and the blue dot cataracts were well appreciated in the slit lamp photograph.
How common Dandy Walker to present it in 19 years? How common it is? What is the prevalence?
So the adult onset Dandy Walker malformation is, the term is used for the presentation that is above the age of 16 years. And only a few case reports are available of this condition. There is no study that has shown this percent of this is the prevalence of this particular condition.
What basically happens in Dandy Walker? Which part of the brain?
So the triad that was described is basically the malformation, and the most striking anomaly that is seen is the high insertion of the tentorium cerebelli, leading to the dilated posterior fossa and the hydrocephalus in the obstruction.
Cerebellum development also?
Pardon, sir?
Cerebellum development?
Yes, because of the
Is
hydrocephalus.
it possible cerebellum is developed at birth and then it is regressed after?
If the malformation is present during development, it is most likely that the abnormal cerebellum is developed. The normal cerebellum cannot develop in that hydrocephalic patient.
So it can be secondary to hydrocephalus also rather than congenital malformation. What do you think?
Yeah, going back.
Your differential can be a secondary complication of hydrocephalus, or you stick with your diagnosis of Dandy Walker malformation?
Yeah, I would like to stick with the diagnosis because the triad was formed. If there was only a posterior fossa dilatation, I would have gone for the secondary atrophy of the cerebellum due to the hydrocephalus.
But adult onset, very rare thing which is not reported all over the world. We should keep a differential diagnosis rather than sticking to one particular.
A differential diagnosis is definitely one of the things that we considered.
You should have mentioned
at
it
that
and
time.
differential also.
Okay, before I call the next speaker, I would just like to remind there are 4 criteria by which we judge, we give Young Achievers Award. One is level and number of presentation of publications, level and number of awards, academic quality of achievement, and originality or innovation or out of the box idea. So please, all the presenters concentrate on these 4 points. So next speaker would be Prasanna Venkatesh Ramesh.
Thank you for this opportunity. So I'm just going to share for the next few minutes why myself for this particular award. So starting from innovations, so this was a hologram that you would have seen in a movie. So these are my 4 innovations that I did in the last 2 years from 2022 to 2023. And you can see them, 6 of them being published in their innovation category, and I call this the metaverse. So this is the 3D augmented reality model that we made in the smartphone. You can see that the left-hand side and the right-hand side are timed, and this was the first holographic model in the smartphone that was made by me, where real confocal images were used, not only the funduses, but also the angle you can see on the left-hand side and on the right-hand side. And you can see again, this is the mobile camera view where the angles are being shown. And not only that, fundus you can see color fundus, autofluorescence, infrared, and this is a case of NTG patient and many more. And next you can see, this is a 4D innovation again with the headsets. You can see we created the real-time 4-dimensional hologram. On right hand side it appears as if he's moving through thin air. On left hand side, the whole case sheet, eye being a 3-dimensional organ, is evaluated 3-dimensionally itself. And again a flecked retina case, you can see that color fundus, autofluorescence, and similar to a retinitis pigmentosa for low vision rehabilitation. And then this is a whole neuroanatomy that was created in the metaverse, that the whole anatomy can we make it because for studying purpose, pedagogy and counseling. And this is the workflow that we have at our system where a diabetic patient comes in. The next layer was added where in this software, not only the fundus, also the OCT, you can see that the different slices of OCT was incorporated so that it can be extrapolated and then the patients can be shown before treatment, after treatment. And also an artificial intelligence workflow was made by me. and this is the flow that you can see. The different annotations were done. Not only the diagnosis, but you will also get the predictions for fundus, as well as this is an anterior segment UBM and ASOCT, anterion and sheen plug imaging. A comprehensive 4 modalities were made, and again for ophthalmic diagnosis and interpretation. And this is a MIGS surgical simulator that was made last year again. When I had this particular eye stent drop, I went back to my drawing board, and then in the metaverse you can see again moving the hands, and this is timed, my dear friends. This is what you see through your eyes on the left. So the same eye stent implantation can be practiced in the metaverse 30 to 40 times, because you don't get models to do MIGS today. So see, when you place it correctly, this turns green, and that was a surgical simulator that I made, and these are the 4 innovations: ophthalmic pedagogy, clinical diagnostics, surgical innovations, and artificial intelligence. I have a teaching channel as well in the YouTube with more than 3,000 subscribers with a lot of animations, and I also make a lot of puzzles in 3D. So this is the first visual fields we have made: circle of Willis, cavernous sinus, and this is an isopter contraction that we made. Can a subject like isopter contraction even be made in a 3-dimensional printed model? So we made that possible. Academics and research, 180 publications, and 69 of them in the IJO has been done by myself, with 12 cover page images, and 1 in ophthalmology glaucoma, that is American Academy of Ophthalmology. And this is my citation profile. That from you can see my citation is 374 with an H index of 9. And this is a recent picture. And these are some of my publications among the 180, published exclusively from national, international to regional, like the Orissa Journal on endothelial study, Kerala Journal during COVID, the Clever Journal, again a Kerala Journal, again IGO. I have 69 publications in IGO on AI and exploratory study in glaucoma. I'm a glaucomatologist, cover exclusively in glaucoma, and these are all my publications, which I'm just quickly sharing for want of time, from clinical to innovation to diagnosis. And these are some of my photographs that has won recently in ACRS, IRSI. These are some of my images, winning as well as on the cover. You can see this ophthalmology, glaucoma and accent-filled rigor, and these are some of my images. And awards, these are some of the awards in the last 2 years. GSI, right-hand side is TNOA, this was last AIOCMTC, and this left-hand side is APAO, and the right-hand side was from IC in IRSI this year, and this was my Kolkata presentation with Yosicon. So I'm not going into the details of it. I'm also an International Ophthalmic Hero Award winner for the last 3 consecutive years for my work on innovations. And I've also won the travel grant for AO's International Travel Fellowship for 2023 and the World Glaucoma Congress travel grant winner of €1,000. And research leadership, I'm currently in the Asia Pacific Academy of Ophthalmology Leadership Development Program and on the editorial board of IJO, TNOA, and a few more journals. And this is one of my live surgeries. So when I spoke to Saurav Luthra sir, he told this is about a testimony of your work in last 2 years. And this is the whole work of mine, from clinical, academic, surgical, innovations, publications, and whatnot. Thank you once again, Dehradun, for the opportunity. Thank you. This is the circle of Willis. I was not able to bring everything, but whatever I could, I just bring it.
No, that's very impressive work. Do you use a special software for designing all these models and metaverse?
Yes, sir. I'm more fond of it. The movies inspired me to do it. I do a lot of video editing from my undergraduate mid-school days. So I wanted to really make holograms in ophthalmology for diagnosing surgical simulations. So that's how I started myself into this. It was started as a simple animation making in 2D that went into 3D. And that's how I made this circle of Willis prototypes, or even this isopter contraction, the normal visual fields. And then came I've not brought my simulator, but again, I have it in my smartphone as well as the headset. With that, you can actually touch and feel the things as well, sir. So it's all patent protected innovations of mine. Under my name is the patent, and I have made it, sir. Yeah.
So do you give it to other people if they want to use it for simulation?
So for the love of teaching, these apps are actually free of cost. The IMG Max, if you have an iPhone today, you have to type EYE space MG space Max. It's actually, the demo is free of cost. And even the IMG Hollow simulator is free of cost, but you need to have a simulator. Each tertiary eye care center will be having an Oculus or a Geo or an Apple. The app has been made by me and it is ready. If you have a simulator, you just need to go and download the application so that you will be able to apply it in the practice of whatever, neuro-ophthalmology or glaucoma. Yes, sir.
Thank you so much.
Thank you. Thank you for the opportunity.
Next speaker would be Vipin Rana.
morning, everyone. So I shall be speaking about myself achievements in the last 1 year, since July 2023 till now. So these are the headings under which I'll be speaking. So the PubMed indexed original articles are 10. These are published in European Journal of Ophthalmology, IGO, NMJI, High Altitude Medicine and Biology, IGO, again High Altitude Medicine and Biology, Romanian Journal, and the European Journal of Ophthalmology. The original articles under publication are 2. These are again under the Romanian Journal and the IGO. And the case reports oblique photo essays which have been published in the last 1 year are 15. This is the iJournal. Again, this red nose case is in the iJournal. This is in DGO. This is in COT. This on the online in the retina rocks. This is a cover image of the iJournal. It has been accepted in the American Academy of Ophthalmology intralenticular dexamethasone implant. And this in the iJournal, this DGO. And this video has been provisionally accepted in American Academy. Again, iJournal, Romanian, and this iJournals. So the book chapters are 3, that is a vascular occlusions with and without macular edema, posterior uveitis and vasculitis, and the third is optic disc drusions. The award in the Vizag in 3rd midterm conference, I got the best free paper award in the comprehensive ophthalmology. And this regarding the organizing capabilities, we conducted the Uveitis Bengal Summit along with the members of the Uveitis Society of the Bengal on 12th December 2023. And achievement as a teacher, is it as the shlok goes, Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Param, Brahma Tasmai Shri Gurve Nama. That is, the Guru is supreme. And what we feel is that if we don't pass this knowledge to our generations, to next generations and to the students, then it is futile. So these are my students who have got the various prizes. And these are my poster presentations in the last 1 year. This is a video presentation which was presented in the Kolkata last year, this March 2024. And these are the faculty presentations. Now, something about the pioneering research in the high altitude and retinal disorders. If we go back to the literature, then there is hardly any data from the India regarding the high altitude disorders. So this was my first paper, Central Retinal Artery Occlusion in young adults at high altitude, which was adjudged as the best paper in comprehensive ophthalmology last year. And this was the first paper on CRO in young patients in high altitude. So CSCR, central serous chorioretinopathy at high altitude, has never been discussed prior to this. And so it was a multifactorial perspective which was published in the High Altitude Medicine and Biology, which is one of the best journals of the high altitude medicine. Hyperhomocystinemia, high altitude and varied retinal manifestation. Again, the association between the homocysteine level and the high altitude, as there are various causes which can lead to the increase in the hyperhomocystinemia. So it was published. And retinal manifestations in high altitude. And this paper has been recently published in the European Journal of Ophthalmology. That is a delayed high altitude retinal hemorrhages in well-acclimatized lowlanders. Regarding the innovations, the first was subconjunctival anesthesia. It was recently published in the European Journal of Ophthalmology. The second is a glaucoma related, and this was a video which was So the retinal related research, this has been published in the Romanian Journal, where we can use a ozil tip for doing the phacoemulsification. So to summarize, the PubMed index original articles are 12, case reports 15, book chapters 3, AIOS webinar on trauma 1, award best paper, leadership qualities, uveitis, meet organization, surgical innovations 3, and the pioneering research in high altitude related articles, 5 articles. So thank you very much for your attention and support. And I would like to acknowledge my family members, Professor Vishali Gupta, my mentor and guide, faculty members, my junior residents, and all my patients. Thank you so much.
So for the high altitude CSR,
Sir.
did you have any different like time scale for resolution, or did you have to do any treatment for it?
Sir, no, the resolution is same, but the causes were multifactorial, and that's what we were thinking, that we can do the further study comparing the CSR in the high altitude and in the lowlanders.
So, was it just like a case, do like a cross-section study? For that?
Pardon, sir?
Did you just do a case
No,
report?
no, no. It was just a case reports. Letter to the editor, sir.
Since you have done the study on high altitude sicknesses, and what do we do for prevention?
In high altitude, ma'am. Oh yeah, basically for the general population who is going to the lowlanders, who are going to the high altitude for the longer durations. So there are various factors. The number thing, first though, we have to go step by step, for which, acclimatization is there, so that acclimatization schedule is there. The second thing is, if you're going for the long term, we should take vitamin B6, vitamin B12 and the folic acid, because that leads to the deficiency in our body, and which leads to increase in homocysteine level, and which may lead to the number of complications which we have shown in our studies.
Any role of smelling camphor when we are at high altitudes?
Pardon, ma'am?
Any role of smelling camphor?
No, ma'am. We haven't seen. In fact, Diamox is given for prevention, ma'am. Yeah, sir, I'm in Army only, so that's why I could conduct, all these studies. And on 2,600 troops, one study was conducted where this recommendation was given to give the B6, B12 and the folic acid. And it was published in the NEJM, sir. Sir.
So for intumescent mature cataract, do you routinely make 25 gauge ports to decompress the vitreous?
Only in phakomorphic glaucoma, sir.
Yeah, but do you think this is do you routinely do these 25 gauge
No,
ports?
if chamber is completely collapsed,
Okay,
and we are
there
not
lot
able
of
to.
other options, like we can use mannitol preoperative.
Yeah, that we do, sir. So those standard things, we do everything. Like I'm a vitreoretinal surgeon, so I'm more comfortable in making that. But routinely we give the mannitol, etc. So that medical management is always done. But despite of that, if chamber is completely collapsed, IUP is high, so for decompression.
Thank you so much.
Thank you, sir.
Next speaker is S. Aisha Raza. She's not here. Then next speaker would be Ritu Singh. Soumya PP.
Very good morning to everyone. Before introducing myself, I should introduce this little toddler. She is my 7-year-old kid who helped me a lot with the achievements that I have right now. Myself, Dr. Soumya, I should call myself a passionate surgeon as well as a dancer, currently working as a glaucoma and phaco-refractive surgeon at Trinity Super Specialty Eye Hospital, Palakkad, which is in Kerala. My educational qualification, I did my MBBS from Government Medical College, Calicut, MS from Regional Institute of Ophthalmology, Trivandrum, Fellowship in Glaucoma and Cataract Surgery from Ahalya Foundation Eye Hospital. My academic achievements past 12 months, in the Kerala Society of Ophthalmic Surgeons, that is KSOS, annual conference in November 2023, I had a surgical video on taming PPZ, the SICS way, and a post on what the mind does not know, the eye cannot see, on neuro-ophthalmology. The Noel Morris Memorial Video Competition have been, which was held in 2024, I had a challenging cataract surgery case. In AIOCMTC Kolkata 2024, which is in March, I have been faculty in the surgical training courses SICS, iris glow, implantation and trabeculectomy, and this is an international faculty who came to study iris glow. He is from Istanbul. And I have been a faculty in the diagnostic training course RNFL OCT, and I have poster presentation what mind does not know, the eye cannot see, which was in the neuro-ophthalmology. I have been chairperson for e-posters, panelist for UKSOS sessions. Coming to the April, it has been UCCon 2024. I am third prize winner in the e-video competition on phacoemulsification technique. And I have been a faculty in the OCT in glaucoma and a video presentation SICS in the posterior polar cataracts. I have been a chair for the session in glaucoma in UKSOS and faculty talk on optic nerve head glaucoma and differentiation from the optic disc. And coming to the IARSA 2024, which is in July, I have been runner-up in the non-ophthalmic photography session. And coming to the World Ophthalmology Congress 2024, Vancouver, Canada, which was in August, I had an opportunity to present a video on the taming posterior polar cataract, the SICS way. The video was in the category of innovation in cataract and refractive surgeries. And an IC course on the phacoemulsification in challenging situation at mastering cataract surgery, which was also in the WOC. And I have been presenting a complicated cataract surgeries, like small pupil, mature intumescent, everything. Coming to the MIT conference, that is AIOS, right now, I have been in faculty talks, free paper presentations, just cases, science and fun participant, finalists for the photography ophthalmic as well as non-ophthalmic, and faculty as well in the SSTC. And my current post is, I have a Young Ophthalmology Launch Kerala Executive Committee member, RIO Trivandrum Alumni Executive Committee member, Palakkad Society of Ophthalmic Surgeons Scientific Committee member, and a UKSOS Cataract Team Initiative. And I am training my junior fellows, PACO and SCCS in my institute, as well as I teaching optometry students. Coming to the leadership development, I have completed my Kerala Society Leadership Development Program. Right now I'm going for the AIOS Leadership Development Program. And I do have a life beyond ophthalmology. I'm a joint secretary of the IMA Palakkad, Indian Medical Association as well as I'm a passionate dancer and a traveler. Thank you. If you want to see the video, I could play the video of the innovative session at the WOC.
Make it very short.
Posterior polar cataracts are a unique subset of cataracts that can pose a challenge even to experienced surgeons. There is an inherently high risk due to the extreme thinness of the capsule with its tight adherence to the polar lens opacity, leading to posterior capsule rupture and even nucleus drop. Vincent. Several modifications have been suggested to enhance safety during surgery. We prefer to do rhexis initially in an intact globe before creating sclerocorneal tunnel in case of compromised entry. While injecting
Should we play?
viscoelastic substance, we need to be careful of the sclerocorneal tunnel. The size of the tunnel depends on the size of the nucleus and the grade of associated nuclear sclerosis. Hydrodissection should be avoided. Instead, Simcoe cannula can be used to gently hydrate and remove the loose cortex. This should be avoided in cases of pseudoexfoliation and cataracts with weak bag. Simcoe cannula is advanced beneath the capsular rim so that the cortex is loosened from the capsule without pressure on the capsule. This gives an effect similar to gentle multiple quadrant hydrodissection. The nucleus is then gently tilted and
Thank you.
Any question?
So in this one, like SICS for posterior polar cataract, how do you make sure that the, because I did not understand how you can take out the lens without, if it's involving the posterior capsule to SICS.
No, I have omitted saying that I don't use, if there is a rent or something, if it has dehiscence, I don't go for this technique. I usually do a phacoemulsification only, sir. For those patients that are not okay with it, we do have in a rent or tailing, fish tailing, nothing like that, I do for this process.
So in a posterior polar, how would you know beforehand whether...
A slit lamp examination will be useful, as well as it is a training institute, my institute, so the children will be the students will be given SICS only for the first time. So they have to learn the SICS, then only go for the phaco. For the SICS PPC, it is a safer method for them.
How would you know on slit lamp that the defect is there? Because posterior polar are normally...
Fish tailing or something is like that, we have to look in. And if there is a mature cataract, we won't be able to see. I do a B scan only for any defect or anything like that to check on that.
Do you do like an anterior segment OCT or something?
No, we don't have that.
Thank you so much.
Thank you, thank you.
So next speaker would be Pawan Puneet Malhotra.
Very good morning to all of you. With due respects to my teachers in ophthalmology, thanks to AIOS, regards to Uttarakhand Ophthalmic Society for allowing me to present my credentials for this prestigious award. Luckily, 3 years short to the age bar, and this year got invited as an international guest speaker, and our innovative SFL technique got acknowledged by American Academy of Ophthalmology. At the international level, credential in the last included, we conducted an instruction course in American Society of Ophthalmology. Thereafter, presented my work on toric IOL fixation in the subluxated cases in Amsterdam Uretina. And in the Bhutan, we presented our surgical management of subretinal bleeds this year. Credential of the last year at the national level included the first prize in the Chandigarh Eye Film Fest, Eminent Faculty Award from MP State Ophthalmic Society, Himachal Pradesh Ophthalmic Society, conducted a invited faculty lecture in North Zone, COS, VRSI, and the RFR organized by PJ for the consecutive 2 years. Coming to the innovation part, this is the
sutureless tail fixation with advantage of not requiring any forceps, any glue, no haptic exposure, no hydrophilic oil, obviously no suture, and can be performed through 3.2 millimeter clear corneal incision 2. Center of the cornea and adjacent limbus marked accordingly. Localized peritomy performed. Infusion source applied. One can use the AC maintainer too. Scleral pockets fashioned parallel to limbus with right-handed directed inferiorly and left-handed superiorly to match haptics direction. 1.5 millimeter marks applied at the entry of pockets. 26 G needle with silicone band segment prepared. 3.2 millimeter corneal entry made. Holder folder forceps. Injector or simple curved forceps to fold and deliver the IOL. Needle brought out taking care not to pierce any corneal tissue. Haptic threaded over 26 G needle followed by IOL delivery. Haptic brought out and retained with the aid of silicone band segment, obviating the need of any assistant. Similar procedure performed on the other side. For haptic insertion, just hold anterior sleeve of the pocket and slide therein only to save off any haptic exposure. Port is hydrated and cautery applied to oppose conjunctiva. Compared to Yamani's, this technique has no trailing haptic issues. A hydrophobic lens is used. No glue or trained assistant for IOL injection is required. No haptic exposure or special forceps as Gerber-Sherrod forceps for haptic insertion is required. Thank you so much.
Luckily, this technique turned out being the most commented technique for the consecutive last 7 months. And we got an invite for the write-up by the PJ in the COS newsletter this year too. The other parts of the SFL we are working on is the SFL tilts. You can see up to 90 degrees of the tilts can be corrected with the tram track suture, and the toric oils can be refixated, like in this case, back to the 62 degree. Other parts, we are working the POBH shoes and traumatic cases, like in the open globe injury cases, closed globe injury cases, the membranectomy cases, as the dialysis with the PC rent, because rather than going for the SFL, it can be used as a sturdy support in such cases too. The other parts are the aspects are the RP choroidal graft and the retina grafts and the subretinal bleed managements. These grafts should rarely be done in such cases with a massive subretinal bleed in the one-night patients, and they are not able to have the contraindication of the VEGF or the refractive conditions. So what we do, after the base dissection vitrectomy, induce the localized detachments, use the fluid exchange to push the fluid behind, then do more than 180 degree RR, and thereafter take all the CNVM complex and bleeds and the cauterize those feeder vessels, as well as thereafter, under the PFCL, mark the area of the, you can see the normal area of the RP choroid. From there we take the graft. You can see the underneath sclera, I just take it with the help of the curved scissor. Then the PFCL is taken from the underneath and put on the retina, followed by the retinal laser and the PFCL oil exchange. The graft, nicely in place, can be seen in the post-op period. We are the first one to do the autologous retina transplants in the country, I will say, since 2018. I got the first best case series prize in 2019. The graft is nicely in place, bridging tissues formed, and at times you can see the underneath photoreceptor layer regeneration too. Subretinal bleeds, whether you manage with the help of BSS, TPA air, or within the diabetic cases from the breaks, you can take the help of the extrusion with the help of cutter, or the external drainage in the cases, or in the traumatic one-head cases where you can use it with the help of a cutter and like a spaghetti drainage. The aim is to create a vision in such eyes. Thank you so much for your patient hearing.
No forceps. So what precaution to be taken before that? To good vitrectomy, other than good vitrectomy, what precaution we should take to avoid any complication?
You know, we have been doing this technique for almost now 4 years, and almost more than 200 cases we have done. The problems with the ex-knee technique was that there was a part of the haptic which remained exposed, and it states the chance of getting the endophthalmitis in the cases. Rather than getting any of the vitreous, as you rightly said, the cases, the hurdle which was faced with most of the surgeons and their segment surgeons, that they were not trained in the SICS. We been trained in SICS, but many new generation surgeons are not trained in SICS. So there was a hurdle for them to make the SICS tunnel. So by using the 3.2 millimeter clear corneal tunnel, it can be done. And other things which should be taken care is while handling the trailing haptic. And you should exchange your right hand to the left hand so that you can use your right hand to insert the trailing haptic in. And this we have been doing for the last 4 years right now.
Retinochoroidal transplant, how many cases you have done, and what is the visual acuity in that cases?
For the autologous retina transplant, I would like to say that we have done almost 12 cases till now. And there are two aspects of this: the clinical aspects and what the study says and what we felt in the real world scenario. The one thing we felt that no doubt the scotoma size decreases. Even in the microperimetry, we have picked that the spots can be the patient started picking. Even in so far the vascular part is concerned, the development of the CNVM itself in such cases, means that there is a vascular connection which has developed. If we see and we have seen the patient gaining vision up to 660, but not more than that, I will accept that. And almost 40% of the patients had the visual improvement, 30% patient did not had. Two of the patients had the detachment also in the initial cases where we were not using the cutter to induce the localized detachments in such cases. Other than this, from the studies, we say that they have been the pluripotency of these stem cells in the peripheral retina has been reported as such, and the immunohistocompatibility of the retina to the central retina has also been reported. But these are all the theoretical parts of this.
Thank you so much.
Thank you, sir.
Next would be Shilpi. After that, Ram Manoj and Sukrati Parida. Am I missing somebody else?
Next news?
Good afternoon, everyone. So, thank you, Scientific Committee, for this opportunity and nominating my work for the prestigious Young Achievers Award. So, let me briefly introduce myself. After doing the post-graduation, have done VR fellowship and then cleared the retina exam in FICO and ICO retina. And for continued education, I have been a member of local, regional, national, and international societies, and have been actively contributing as well in their scientific programs. But I still remember my very first national subspecialty presentation at VRSI 2016, when Dr. Rosenfeld, the father of Avestin, came to discuss about the role of EDI in diabetic retinopathy in person after the session and asked me to publish, which also became my first publication. A non-existing person opinion sought by the great Rosenfeld probably was the trigger to a hidden researcher in me, and now have more than 45 publications to my credit, some case reports and images. So this is the citation index of our articles. Our images have drawn the cover pages of various journals like Ophthalmology, which is the journal of AAO, and Eye Journal. Feel great pride in sharing with you all the cover pages with these prestigious journals with our cover pages. Now have been invited as a reviewer for various journals and editorial board member of Official Journal of Maharashtra Ophthalmological Society. And I have been a principal investigator of various trials of DME and CNVM. Now coming to the awards, I have also won 2 back-to-back APOTS Best Video Awards in 2018 and 2019, and the reverse Swiss roll technique described by us for the diabetic membranes discussion won the 2nd Best Video Award for the New Innovations category at IRSI 2021. Of course, images have been our forte and have won awards at AIOC and at VRSI. But I'm just not a bookworm and have been a quiz master in Big Q, which is the first ever online All India PG quiz since last 3 years, a fun-loving sports person, and have done short-term management courses and leadership development program at prestigious Pegasus Bangalore and IIM Ahmedabad. So now looking back towards the 23 and 24 contributions, I have continued my contribution as a faculty at various forums, and I'm proud to share that I have been invited to IROP Consensus Committee Meeting 2024 for framing guidelines for ROP in India. Thankful to the ACOIN for conferring this oration during their meet in April 2024. At ASRS, besides these participation in the form of 2 films and 1 case presentation, was honored to be a part of expert panel in one of the session on macular holes. This year, we had 2 case reports, one in iJournal and another in IGO. These are the 3 original articles published by us in this academic year. And this was the cover image of IGO. Besides the above published articles, there are 2 original articles accepted for publication in this year and 5 cover pages all in the iJournal, which is an official journal of United Kingdom. And proud to share that our work on retro mode, a newer insight into the dry AMD, was awarded the best paper in the subject of vitreoretina, that is Suresh Limay Award by Maharashtra Ophthalmological Society. Have been lucky to have back-to-back best video awards at Midterm Patna and Vizag. ASCRS 2024 at Boston has been a very lucky meeting for us, as 4 of our images were awarded in various categories. And the icing on the cake in this year has been the Image of the Year award, awarded to the image on Takayasu by ASRS 2024 at Stockholm. So last year have been very kind on us, and just to recall on the honors in a nutshell, an ACOIN oration, 6 published articles, 7 in print, 1 Best Paper Award, 2 Best Video Awards, 4 Image Awards at ASCRS Boston 2024, invited faculty at ASRS Stockholm 2024, and the cherry on the cake, that is Image of the Year Award by ASRS 2024. Thank you so much.
The images which you have taken, they are quite good. Which camera have you used in those? Or is it like a
Sir, maximum are done on the Mirante by Nidec. Few anterior segment images are other that ROP images, that is retinoblastoma, that is on the Neoret camera by Forus.
Thank you so much.
Thank you, sir.
Now, Ramanuj.
At the outset, I would like to thank AIOCMTC and UKSOS for the opportunity. So I'll be presenting our original work on post-COVID endogenous endophthalmitis, which we published in the last year in Indian Journal of Ophthalmology. So various ophthalmic features involving anterior and posterior segments, optic nerve and orbit have been described in COVID-19. So our purpose was to describe the series of endogenous endophthalmitis following post-COVID-19 from a tertiary multi-specialty institute. So a retrospective chart review including all consecutive cases with endogenous endophthalmitis following RT-PCR confirmed COVID-19 from July 20 to June 21 was done. We got the institutional ethics committee approval, demographic characteristics, comorbid illness, preoperative characteristics, comprehensive ocular evaluation, all were done. Systemic evaluation by physicians were noted and appropriate lab and radiological investigations were noted. Patients with clinically suspected endogenous endophthalmitis were initially treated with vitreous tap and intravitreal vancomycin, either amphotericin or voriconazole. And systemically fit patients who did not respond to intravitreal injections after 48 hours were subjected to PPV and repeat intravitreal injection. Diagnosis of confirmed fungal etiology was based on microbiologically proven fungal elements from the vitreous aspirate. The outcome measures included the visual recovery and control or resolution of intraocular inflammation. So this is the first patient. In the left panel we can see hypopyon and the B shows a dense vitreous exudate, and post vitrectomy the patient's media improved significantly. The second panel, second column showed there is a infiltrate, retinal infiltrate in the nasal hub and mid peripheral granular infiltrate, and following multiple intravitreal injections that resolved well. This patient also had suffered from severe COVID pneumonia and turned into a steroid-induced diabetes mellitus. Also had bilateral brain tuberculoma and cavitary lung lesions. She also had history of pulmonary TB at past. We treated also with systemic antifungals. The second patient is a 63-year-old lady who had moderate COVID, treated with steroid elsewhere, turned steroid-induced diabetes mellitus. She also had right-sided hydronephrosis. So both eye received intravitreal injections followed by both eye pars plana vitrectomy. Also received systemic voriconazole, but she developed voriconazole-induced hallucination. So she was shifted to oral ketoconazole, and at the final follow-up, her vision improved and the anatomical integrity was also there. The third patient was a 48-year-old lady who suffered from mild COVID, no prior comorbidities. The right eye received intravitreal injection. We can see multiple fluff balls in the vitreous cavity. Intraoperatively, a subretinal abscess was also noted, and the vision was also improved marginally after surgery. The fourth case is a 45-year-old lady. She suffered from a severe COVID pneumonia, received IV steroid, had a prolonged ICU stay, also developed pulmonary hypertension. The HRCT chest showed post-COVID sequelae with fungal infection, and the bronchoalveolar lavage showed septate hyphae with acute angle branching. These are the focal retinal infiltrates protruding into vitreous cavity. These are bedside images with the 20 diopter lenses, and following intravitreal injections, they undergo organization. So these are in nutshell the range of the COVID, prior COVID ranged from mild to severe illness. 2 patients had steroid-induced diabetes mellitus, and some of the patients were treated with, almost all of the patients, 3 patients were treated with steroid previously, and time since COVID varied from 3 weeks to 8 weeks. And the present, all of these patients were treated with intravitreal injections, and 3 patients were treated with pars plana vitrectomy also. So coming to the literature, we can see that in the literature, post-COVID endogenous endophthalmitis have been described by few authors from India and abroad. The eyes varied from approximately 3 eyes to 10 eyes in the literature. Most of the Indian studies have reported fungal endogenous endophthalmitis in the form of Candida and Aspergillus, whether the outside studies have also reported bacterial endogenous endophthalmitis in the form of Klebsiella, Strenotrophomonas, and MRSA. So in conclusion, high index of suspicion is required for patients receiving prolonged systemic corticosteroid following COVID-19. Bedside fundus evaluation needs to be encouraged. Timely systemic and intravitreal antimicrobial agents plus PPV is essential for favorable outcome. Vigilance is required for uncommon but possible drug-induced side effects like voriconazole-induced transient hallucination. Meticulous history, detailed systemic evaluation, appropriate investigations, and a prompt multidisciplinary approach are important for achieving a favorable outcome. So this endogenous endophthalmitis is not only important for post-COVID, but also being in a tertiary institute, I see a lot of endogenous. In recent times also post-dengue, we also see a lot of these patients. So these patients do not only lose vision from the disease itself, but due to some treatment after the primary illness. Thank you. Yes, I have a lot of publications, but according to the criteria, I thought this is about a single publication, so I did not mention any one of them.
What are your awards?
I can tell I have overall 85 publications, and overall I have around 350 citations. My H index is 9, and in the last 1 year I have published almost 20 articles, and all of them in the PubMed indexed journals. So I am in a postgraduate teaching institute, so I am the guide for 5 postgraduate students and also co-guide for the DM students, and I am also regularly participating in various national and international conferences as a faculty. But for sake of presentation, I thought this was about a single according to the criteria, so I was not
Any awards you won?
So I got the Oration Award in Kolkata, one Oration Award, and I got the Best Surgical Video Award in the Winter Dose. These are the recent.
Any international?
No, I attended international, but there is no international award within one year. Yes, I went to the South Bhutan International Faculty Presentation this year only.
What was the topic?
My topic was retained intraocular foreign bodies case-based practical approach.
Thank you.
Thank you.
Last speaker is Dr. Parida. Anybody else left to speak? You would be? Third.
My presentation is titled Actions Speak Louder Than Words because I believe that I would like to define myself by my actions rather than by my words alone. So the objectives of this presentation are to enumerate my achievements and talents, to be a source of inspiration for all the budding ophthalmologists, and to get inspired by my counterparts and seniors in this field who have achieved multitude of laurels and to carry their legacy way ahead. So, my brief introduction, I am Dr. Shrutakirti Parida, currently working as Assistant Professor in the Department of Ophthalmology, KIMS, Bhubaneswar. I have completed my long-term fellowship in Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology from the prestigious L.V. Prasad Eye Institute in 2022. I have been the gold medalist and batch topper in MS Ophthalmology and also in my MBBS career in the Barampur University. Coming to my awards, I have won the Best Paper Up Session Award and the Best Paper in Pediatric Ophthalmology section at 2nd AIOCMTC3 Vizag in the paper session with the title Effect of Low Dose Atropine on Choroidal Thickness in Children with Myopia Progression. I got the 3rd prize in Adult Neuro-Ophthalmology pre-paper session at an international conference, WCPOS, at Malaysia this year, and my paper was titled Post-Fever Optic Nerve Disorders and its Visual Outcomes, a Prospective Interventional Study. Coming to my presentations, I had a pre-paper presentation titled Clinical Demographic Profile and Visual Outcomes of Pediatric Traumatic Cataract, a Prospective Study at AIOS 2024 Trauma Section, case presentation in Neuro-Ophthalmology session at Vizag, physical poster presentation at AIOS Kochi in the Squint section, then e-poster presentations which are multiple in Kochi in WCPOS, 2 e-poster presentations. Then I have just moderated the Neuro-Ophthalmology pre-paper session 2 at AOS 2024 Kolkata. I have been awarded the Best Mentor for Teachers of Tomorrow at Midterm OSOCON 2024, and also currently I am mentoring my PG students at Midterm AOS this Dehradun. I have given the invited faculty talk at Aquine International Conference, Puri, in pediatric and strabismus session. I have also a faculty talk in neuro-ophthalmology session at this midterm conference on post-fever optic nerve disorders. Coming to the list of my publications, this is for this current year. These are the list of the publications: the clinico-epidemiological study in blunt ocular trauma and its visual outcome, occupational radiation exposure and cataractogenesis, the impact of active vision therapy and binocularity for anisometropic amblyopia, and few case reports. Now coming to my passions beyond ophthalmology, I am a trained classical dancer. I love to sing. I write essays, short stories, and poems, participate in various debate competitions, enact plays and dramas, and have got various best female actor during my MBBS days also. I love to cook and also like gardening. And beyond that, I'm a proud mother who loves to spend quality time with my daughter and my family. These are the various roles I have played in my life. And being an empowered female, that is a double-edged sword, I believe, because you have to be an ophthalmologist, you have to be a surgeon, and also you have to be a family person. And I have tried to give justice to each and every role, whatever I play. So before ending, I would just like to quote Dr. Robert Frost: "Woods are lovely, dark and deep, but I have promises to keep. Miles to go before I sleep, and miles to go before I sleep." Thank you.
So, a very good afternoon, everyone. I am S. Aisha Raza. I am a senior resident in Department of Ophthalmology at Aligarh. So, I was of the opinion that we have to say about our innovation here. So, just I have one of my innovations. That's why I wanted to tell you people. It's not going forward. So, I'll be telling you people about the pocketable HES chart which I considered my innovation. So, HES screen test stands the test of time. It is based on haploscopic principle, which aids in diagnosis, progress, or recovery over time of paralytic strabismus. So, it needs no introduction. But then we designed a portable HES chart based on the same principle. So what we did was, we replicated the HES screen with similarly shaded cotton cloth. We laid the cotton cloth over the original HES screen and then marked the points of red LEDs with a marker pen, with a permanent marker, and then we suspended the cloth on the wall. So the examiner used red laser pointer light here, like this, and then the subject or patient wore red-green goggles and employed the green laser light. So the patient or subject was asked to superimpose the green laser light on the red. So it was done both for the inner and the outer field, and simultaneously we recorded the location of green spot on the record sheet. Goggles were reversed and then to record the secondary deviation. And we have hung the cloth at 1 meter distance. So each 1 centimeter on chart would by definition qualify as 1 prism diopter of misalignment. We now explored the use of this chart in 3 stages. First stage, 5 healthy residents were asked to wear the red-green goggles. Then examiner flashed red laser light, and each resident was given green laser light and asked to place it on the red laser light, and the latter being shifted amongst various points at randomly on charts. So the complete and precise superimposition was present. In the second stage, we induced a vertical or horizontal strabismus, and then of 20 PD, 25 PD prism in one eye, and asked to superimpose the green laser light on the red. So the distance on the chart correlated with the magnitude of the prism used. Now with these things, we are reassured with the patients, with the things, these results were applied to the patient given below. These are some pictures. I would like to highlight the fact here that it can be done on the bedside. I am doing it here in medicine ward. So documentation of field of action of individual muscle is being practiced since a long time. It's nothing new. But then our modified HES chart is low cost, foldable, eminently portable, and then reproduced almost similar chart as compared to the standard equipment. And the cost is also, as compared to the readily available hair screen, is less, around 800 rupees, and it weighs also, like, just to tell you people that it is like quite portable. So concluding that, a unique combination of older idea of using cloth as a screen and red and green laser light as light source. It's low cost, handy, portable, and easy to use. And it's simple, reproducible, objective, and quantitative assessment of disorders of muscle balance in patients with diplopia, even bedside. So, like, right now I have made this slide for myself. So I have done my fellowship from Shankar Netralaya in pediatric ophthalmology and strabismus. I have qualified FICO and FAICO. I have 7 publications in Indian Journal of Ophthalmology and 1 in Oman Journal of Ophthalmology. I have won this Yogesh Shukla Gold Medal Award for Best E-Poster. Recently in SPOCI also, I have presented one unique way, novel suturing idea for resection. So here it is. It's not that much edited. So, like, it is for the newer people who are a bit reluctant in cutting the muscle beforehand.
Repassed
So
at
after
the
attaching
resection
the
site
muscle on the insertion,
from
then
under
we
surface,
cut the redundant
exiting
muscle.
externally, tied firmly after effecting
we have already attached
approximation
it,
to
and
the
now we are cutting
insertion.
it. So, thank you. Sir, actually, I was of the opinion that it's just one innovation I have to, just RN Singh Innovation Award. That's why I have